Thank you. So we can move on very quickly to our didactic session, but I would start by introducing our speakers. One of our speakers is Dr. Francis Agyekum. He is a senior lecturer at University of Ghana Medical School and a consultant cardiologist at the Korle Bu Teaching Hospital. He also serves as the training coordinator for postgraduate training in maternal medicine. Dr. Agyekum, who is a fellow of the West African College of Physicians and the Ghana College of Physicians. He has a master's in preventive cardiovascular medicine from University of South Wales, and he has a postgraduate certificate in interventional cardiology from the Guangdong Cardiovascular Institute in China. He has his research interests in genomic and environmental determinants of cardiovascular diseases, with a specific interest in hypertension, heart failure, and I will try not to ruin this word. I have struggled with it all my life. Atherosclerotic cardiovascular diseases. So it's just to point to you that we're very intentional about the experts that are bringing these lectures to you, because they have extensive experience and expertise, but also they have a passion for these things that they speak about. He has been part of many research projects, including the stroke project in Africa, the Siren project, and the anticoagulation project in Africa. The Ghana Heart Initiative, he's plays a very key role in that as well. I mentioned this earlier during the introduction. The DVT Plus project and the Cardiovascular Disease Risk Factor project under the Ghana Heart Study in Ghana. He is the current vice president of the Ghanaian Society of Cardiology, and he is married with 3 children. So please, a round of applause in the chats for Dr. Agyekum. You better start clapping before he will change his mind about giving us the lecture today. So I want to see all the hand claps in the chat. And then I'll also introduce our other speaker. Our other speaker today is Dr. Seth Nani. He is a physician specialist and a cardiologist. He's a fellow of the Ghana College of Physicians and Surgeons and is a member of the West African College of Physicians. He graduated from University of Ghana Medical School. If you graduated from University of Ghana, please rep your school in the chat. Please rep your school in the chat. And then he later obtained his membership certificate as a physician specialist from the Ghana College of Physicians and Surgeons, as well as the West African College of Physicians. He obtained a postgraduate diploma in preventive cardiovascular medicine from University of South Wales as well, and a fellowship in cardiology from Ghana College of Physicians. He's a member of the Ghanaian Society of Cardiology. Dr. Nani is involved in the Ghana Heart Initiative program as well. He has developed cardiovascular guidelines in the country and has served as a trainer in the dissemination of the content of this particular guidelines. He's involved in monitoring of the uptake of cardiovascular interventions. His goal pretty much is being part of this is to improve cardiovascular services. He's spearheaded the services that's spearheaded by the GHI, Ghana Heart Initiative, in healthcare centers across the country. He's also privileged to be part of the team that are looking at the prevalence of deep vein thrombosis, DVT, in admitted patients in Ghana, which is a very critical piece of work. And the aim is for us to continue to determine the outcomes of DVT over a 12-month period and establishment of thrombotic clinics. He's passionate about this practice of cardiology in Ghana, very passionate about it and its impact on the well-being of Ghanaians, and of course I would dare say Africans as a whole. And his aim is to continue to help improve cardiovascular services in the country, which would also have a ripple effect across the continent as well. Teaching and mentoring medical students is what he also does, house officers, medical officers, as well as residents in training. So please, a round of applause in the chat as well for Dr. Nani, so that he too will not say you people have not welcomed him well. Please, Africans, we know how to welcome our own very well. So please, round of applause. Yes, thank you so much. I see it in the chat. So we'll go very quickly to Dr. Francis Agyekum. Dr. Agyekum, I think you'll be able to share your screen. You have been enabled to do so. So please feel free to take it away. And I will let you know when you have 5 minutes left. So you hear me interject at some point, just so that you know what time you have left. Thank you.
Yes. Can you hear me now?
Can hear you. It's a bit draggy, slightly
Can
draggy.
I be heard?
Yes, now we can hear you. Yes, please go ahead.
Okay. So good afternoon. Very happy to be here. And thank you, Adora, for your nice introduction. Makes us feel big, but we are not that big. So the main objectives of this afternoon, just to dive straight into it, is to define and also classify what heart failure is. We will try to briefly discuss the pathophysiology and how to diagnose heart failure. We will discuss the current management of heart failure, and then Dr. Nani will come in to discuss the management of heart failure in special populations. It's a bit loaded, but we are sure it will be very beneficial to those present here. We do know heart failure is a complex clinical syndrome. It is not a single disease entity. It is made up of symptoms and signs that result from a structural or functional abnormality of the heart. And it's a very common cause of hospital admissions the world over. It affects about 1 to 2% of the global population. Wherever you take in, as your age increases, your risk of developing heart failure increase. So if you take people who are about 85 years and above, then you are looking at 1 in 7 people having heart failure. If you are born, your risk of getting heart failure increases as your age increases. There is a new definition for heart failure, and this definition was a consensus definition which is meant to be universal across the world, approved by several authorities. And it defines heart failure as a clinical syndrome with symptoms and signs caused by structural and or functional cardiac abnormality and corroborated by elevated natriuretic peptide levels and or objective evidence of pulmonary or systemic congestion. So the main important thing is that the focus is on the symptoms and signs, not the asymptomatic kind of left ventricular dysfunction. Symptoms and signs, and this is resulting from either structural or functional abnormality of the heart. And this may be corroborated by evidence of congestion, which may be from natriuretic peptide, from pulmonary congestion, which may be from the hustle of the lung. So all these are part of the constituent definitions of heart failure. It is indeed a very common condition that affects so many people in the world about heart failure, adult population. And this is expected to increase. And there are certain factors that have contributed to this. The aging population. As you age, I said earlier on, your risk of developing heart failure and other comorbidities increases. Also increasing prevalence of risk factors. Now, the prevalence of hypertension, prevalence of diabetes, and other dyslipidemia and other things are increasing. And this also increases the risk of developing heart failure. And also the improvement in our management of myocardial infarction and other cardiac emergencies. So this creates a population of people who have structural heart disease and eventually may trip into heart failure. Not only that, the mortality associated with heart failure is also very high. It's estimated that the 5-year mortality of heart failure is about 50%. What that means is that if you diagnose people with heart failure in the next 5 years, about half of them will not be alive. And this is very important. We need to recognize that. Sometimes you tell people you have cancer and they start crying. You tell them you have heart failure, oh, thank God, I can manage it. But the truth of the matter is that the mortality associated with heart failure is higher than the mortality associated with any other cancer you can think about. The 5-year mortality of breast cancer is about 10%. That of Hodgkin's lymphoma, about 14%. Even leukemia, people are so much afraid of the 5-year mortality of leukemia is about 40%, but the 5-year mortality rate associated with heart failure is about 48%, close to 50%. That is why we as clinicians do not have to downplay the significance and the urgency that is supposed to be associated with heart failure. One of the major reasons why heart failure has such a high mortality is also its admission rates. Heart failure admission rates are very high. If you take the developed countries, heart failure is the primary cause of hospitalization for the adult population. And the other thing is that every hospital admission that is as a result of heart failure begets another admission. That is the rehospitalization rate. The 30-day rehospitalization rate in heart failure is about 1 in 4. That is 25% of people who get admitted for heart failure within 30 days will get readmission. And every admission for heart failure sets off a spiral where the patient is more likely to get another readmission, and that is the spiral nature of heart failure until the person's condition deteriorates progressively. These hospital admissions and heart failure itself leads to reduced quality of life. Several studies have shown that, and if you take the quality of life, the KCCQ score, the study that was done in 505 patients with heart failure, the quality of life is worse when the severity of heart failure is high. In other words, the quality of life for patients with heart failure, say a class 1 heart failure, is better than that for patients with class 4. Have poor quality of life, they are more likely to be admitted. So if you have your score is less than 25%, then your risk or your chance of getting admitted for heart failure is higher than somebody who has a score of 75 and above. Another important aspect that we don't have to lose sight of with respect to heart failure is the economic burden that it places on people. There are two aspects to this economic burden. We have the direct cost as a result of the heart failure, and the indirect cost because patients are not able to go to work. In our part of the world, heart failure tends to affect people who are in the productive age group compared to in the United States, in the UK, average age of patients with heart failure is around 71, 72% years. In Ghana, all the studies that have been done, the average age of patients who have heart failure is around 52, 53 years. So these are people who are in their productive age group and they tend to get heart failure and therefore unable to have productive lifestyle. But the direct cost of heart failure is also very significant. This study was done in Nigeria, looking at the components of the cost to heart failure. And about 44% of the cost was the indirect cost, 56% was direct cost to the patient as a result of heart failure. Some of them due to medications, laboratory investigations, transportation to hospital, and other things. So these are the main components. Heart failure places a huge burden on the patient and on the whole family that you and me need to be aware of. So it is important that we are able to identify patients with heart failure, patients at risk of developing heart failure, and manage them appropriately. So what are the etiology of heart failure? We could look at it from the structure of the heart, so from the myocardium, pericardium, and the other structures of the heart. Diseases affecting the myocardium like myocardial infarction, cardiomyopathy, myocarditis. These days, one of the common causes of myocarditis is COVID infection. So COVID leads to myocarditis, and that can lead to heart failure. Pericardium, pericarditis or pericardial tamponade, endocardium, as in endomyocardial fibrosis, diseases affecting the heart valves, like valve stenosis or regurgitation, infective endocarditis. Then you have diseases that are affecting the vascular system, hypertension, coronary artery disease, aortic dissection, and sometimes no structural heart disease, but metabolic disorders that may lead to heart failure. Severe acidosis, severe sepsis, all these can lead to heart failure. By and large, the majority of patients who develop heart failure have certain risk factors. And so when you see patients with these risk factors, then their chances of having heart failure are high. So patients with hypertension tends to be the #1 cause of heart failure, especially if that patient also have left ventricular hypertrophy. So a hypertensive patient with left ventricular hypertrophy on the ECG or on the echocardiogram, this patient's risk of developing heart failure is high. Similarly, patients who have valvular heart disease, coronary artery disease, cardiomyopathies, alcoholism, excessive use of alcohol, and I've mentioned infection already, diabetes, and other conditions. There are others that predispose patients to developing atherosclerotic cardiovascular disease, and these patients are also at higher risk of developing heart failure. So if you have obesity, old age, smoking, high cholesterol levels, and sleep apnea, all these will predispose patients to developing atherosclerosis and myocardial infarction and subsequent heart failure. This was a study that was done in Kolembu in 2000 by Professor Amwa, and the #1 reason why people presented with heart failure was hypertensive heart disease. So hypertension is the most common cause of heart failure in Ghana, and I dare say in the world. If you go to the Western world, they are looking more at ischemic heart disease, but in our part of the world, hypertension. At that time, rheumatic heart disease was the second most common cause of heart failure, then cardiomyopathies, coronary, congenital heart disease, and then ischemic heart disease. So these were the most common causes of heart failure in the Kolembu Teaching Hospital in 2000. Then in the year 2014, Professor Wusu and co looked at the causes of heart failure in Komfanochi Teaching Hospital. There again, about 45% of patients who were admitted for heart failure was as a result of hypertension, followed by rheumatic heart disease, cardiomyopathy. So basically not that different. Now we have degenerative valvular heart disease as a result of aging population. So that causes are coming up, but by and large, the most common causes are hypertension. These days, we are seeing a lot of ischemic heart disease as well, and so that becomes a significant cause of heart failure. I know many people don't love pathophysiology. I will just spend a few slides talking about pathophysiology and not make it too academic. The main reason why people develop heart failure is as a result of injury to the heart. And this injury may be a structural injury or a functional injury. Once the injury has occurred, acute injury occurs like myocardial infarction or acute coronary syndrome, or a chronic injury like hypertension, long-standing hypertension. These are all forms of injury to the heart. Once the injury occurs and leads to reduction in the stroke volume, the body tries to recover from this stroke volume, tries to correct by stimulating some compensatory mechanisms. These compensatory mechanisms are initially very good. The Frank-Starling mechanism, the neurohormonal mechanisms, they are good in trying to maintain the cardiac output, but persistent stimulation, activation of these compensatory mechanisms become detrimental to the heart. They lead to secondary injury to the heart. So if you take a look at this, the primary injury occurs leads to a reduction this sets up the compensatory mechanisms, which tries to return the heart to its normal function. But the persistent elevation of this or activation of these compensatory mechanisms then leads to secondary damage to the heart that tends to perpetuate the heart failure process. So a vicious cycle is then set off. And for you to be able to manage this heart failure, you need to break that vicious cycle. The main organs that are involved are the kidney, the heart, the peripheral vasculature, and the adrenal glands. And all these, at the cellular level, a lot of things are going on. Cellular death, cellular injury, cellular deposition, so many things are going on at the cellular level, which I don't want to bore you this afternoon with. But remember, because of the reduction in the cardiac output, there's going to be a reduction in the renal perfusion. And once there's reduction in blood flow to the kidneys, there's going to be release of renin and other processes will follow. The same way in the heart, due to the stretching of the heart, there's release of natriuretic peptides. Also, this stress in the heart causes myocyte death, necrosis, and apoptosis. And all these things would then lead to further damage to the heart. So basically, initial injury causing compensatory mechanisms, which then become detrimental and therefore leading to secondary injury to the heart. One important mechanism we need to remember when we are discussing the pathophysiology of heart failure is the neurohormonal mechanism, because a lot of the therapy for heart failure hinge on these neurohormonal mechanisms. And the main organs, as I've already mentioned, the kidney, the adrenals, the heart, and the vasculature. So renal hypoperfusion or reduction in blood flow to the kidneys as a result of the reduced cardiac output leads to release of renin. Renin converts angiotensinogen to angiotensin 1. This angiotensin 1 is not the active hormone. So it is converted to angiotensin 2 by the angiotensin converting enzyme in the lungs mainly. And this angiotensin converting enzyme can be inhibited. Once you are able to inhibit this enzyme, you break the vicious cycle that is set off. Or angiotensin 2, what is produced from the angiotensin 1, it causes this effect through the angiotensin 1 receptor. So if you have a drug that can attach itself to the receptor, block the receptor, then even though angiotensin 2 is produced, it will not be able to effect its changes. And that is also another target for managing heart failure, to break this vicious cycle. Angiotensin 2 is a very potent stimulator of the adrenal glands and also potent vasoconstrictor. In the adrenal glands, it causes release of aldosterone, and this aldosterone causes fluid and water retention. If you are able to block the effect of aldosterone through the use of mineralocorticoid receptor antagonists, then you can also break this effect of the neurohormonal activation, and that is also achieved through mineralocorticoid receptor antagonists. Due to the reduction in cardiac output, there is sympathetic overstimulation during heart failure because the carotid sinuses sense a reduction in cardiac output, stimulate the release of sympathetic nervous system, and this can also be blocked or interrupted with the use of beta blockers. So once you give patients specific types of beta blockers, you can also interrupt the cycle that is associated with heart failure. And another one is the stretch in the heart. We increase the diastolic stretch of the heart, causes release of atrial natriuretic peptide from the atrium and beta natriuretic peptide from the ventricles. These natriuretic peptides have effects that are opposite that of the sympathetic nervous system and the renin-angiotensin-aldosterone system, but they are broken down quickly by the neprilysin enzyme. So if you have a drug that can block the neprilysin enzyme, then you have a lot of this natriuretic peptides available, and they can effect its positive effect on the heart. So there is a fine balance that needs to be kept in patients with heart failure. You have the sympathetic activation, renin-angiotensin system activation, and also the natriuretic peptide. So in your management, you are trying to reduce the sympathetic nervous system, you are trying to reduce the renin-angiotensin activation, and you are trying to enhance the natriuretic peptide because they have beneficial effect. And that is the bedrock for the management of heart failure in the 21st century. Another thing I wish to remind you about is how to classify heart failure. We know about the New York Heart Association classification of heart failure. Now we also have this new classification that focuses on identifying the earlier stages of heart failure and your ability to prevent them from progression. So patients who are at risk of heart failure are said to be in stage A heart failure. And these patients, the main thing is that they have risk factors for heart disease, but they don't even have a structural heart disease. So they have hypertension without left ventricular hypertrophy, or they have a family history of heart disease. So these patients are said to be at higher risk than the general population. So they are stage A heart failure. What you do for these patients is to identify the risk factors and try to manage it. Stage B are said to be pre-heart failure. They are those who have structural heart disease, but they do not have symptoms related to heart failure. So they either have structural heart disease or they have elevated natriuretic peptide levels or elevated cardiac troponin, but do not have symptoms and signs of heart failure. What do? Manage the structural heart disease, manage the underlying cause. And then these patients, a lot of them will also benefit from beta blocker therapy. They will benefit from renin-angiotensin aldosterone system inhibition as well. Stage C patients are those who have symptoms of heart failure. So they have structural heart disease or functional heart disease, and therefore develop symptoms of heart failure. And these are either heart failure with preserved ejection fraction, heart failure with mildly reduced ejection fraction, or heart failure with reduced ejection fraction. And then, of course, the last stage are those who are having recurrent symptoms and admissions for heart failure despite therapy. And these are said to be stage D. This is the advanced form of heart failure who will need advanced therapeutic approaches as well, and cardiac rehabilitation to be able to address some of the problems that are associated. I also remind you of the classification of heart failure with ejection fraction. I think I've mentioned it in passing. So heart failure with reduced ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with preserved ejection fraction. It is important to give accordingly because these impact on your decision, your management decisions a lot. There are specific recommendations for these kind of patients because their characteristics are not the same. So you try to get echo and address some of these issues that are associated. Sometimes patients may have heart failure with reduced ejection fraction, but with treatment, they may improve. You do not think that, but you just say they have heart failure with improved ejection fraction. But patients with heart failure preserved ejection fraction, for instance, if their heart failure, their ejection fraction gets reduced, then you label them appropriately. So it is not a static classification of heart failure. You reassess your patients, and depending on what the ejection fraction is telling you or what the clinical characteristics are, you then classify your patients accordingly. I think my time is fast spent, so I'll skip some of these things. This is just to compare the characteristic features, but as I said, they are not the same. Heart failure preserved ejection fraction tend to be more common in elderly, in females, in patients with hypertensive heart disease, and unlike heart failure reduced ejection fraction, which is more common in patients with dilated cardiomyopathy and ischemic disease, and others. So how do you evaluate patients with heart failure? If a patient has suspected heart failure based on risk factors, symptoms, and then abnormal ECG, it is important to then evaluate them well. And I've mentioned echocardiography as one of the ways. We do not have natriuretic peptide easily available in Ghana, so a lot of the times we don't do. But if you are at a facility where it is available, it is one of the quick ways to also help you diagnose. Then, if all these are abnormal, you have confirmed the diagnosis of heart failure. Based on the echo, you classify the patients and then you determine what therapy will be appropriate for them. By and large, the symptoms we are looking at are breathlessness, orthopnea, paroxysmal nocturnal dyspnea, reduced exercise tolerance, fatigue, tiredness, and ankle swelling. And then the less common ones are nocturnal cough, wheezing. These are things you know already: confusion, depression. They bend down, they feel breathless. And then the specific signs of heart failure, you elevated JVP, hepatojugular reflux, S3 gallop, and then displaced apex. So if you're able to find some of these things and coexisting, then your diagnosis of heart failure is more likely. What investigations do you have to do? We have mentioned initial ones. Broke BMP may not be available in many of our facilities, but if it's there, very useful. ECG, very useful. Echocardiogram, very useful. Chest X-ray to help confirm pulmonary edema and also whether there is any lung infections as well, and other routine laboratory investigations like thyroid function tests, electrolytes, full blood count, BB and creatinine, iron status. All these things are important to fully evaluate your patients for heart failure. Now, I'll quickly look through some of the guidelines for the management of heart failure and bring my session to a close. Traditionally, the management of heart failure has been start with ACE inhibitor or ARB plus a beta blocker. If patient is still symptomatic, add a mineralocorticoid receptor antagonist like plerinone or spironolactone. If they are still symptomatic, then change your ACE inhibitor or ARB to an ANI. And this takes several weeks and months for you to achieve optimal therapy for your patients for heart failure. So the paradigm has shifted. Now, we are saying that there are 4 foundational drugs for the management of heart failure. And these foundational drugs are ACE inhibitors or ANI, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. ACE inhibitors, example like Sinopro, Ramipro, or the PROS will be ACE inhibitor. ANI, there's only one available now, the sacubitril valsartan, that is Uperio. Beta blockers, there are only 4 beta blockers that can be used in heart failure. You have carvedilol, bisoprolol, metoprolol, and nebivolol. These are the only beta blockers that can be used. And then mineralocorticoid receptor antagonists, there are 2 of them that have been approved for use in heart failure, plerinone and spironolactone. SGLT2 inhibitors, there are 2 of them that have been approved for use in heart failure, empagliflozin and empagliflozin. So these constitute the foundational therapy for heart failure with reduced ejection fraction. As much as possible, all patients with heart failure with reduced ejection fraction expected to be on this unless there's a contraindication. I appreciate that some of the facilities, we may not have some of these medications available. So in that case, just see them use some furosemide to decongest their lungs and refer them to the next facility, which can then manage them appropriately, because these drugs have been shown to be very useful and improve the survival that is associated with heart failure. And they all have class 1 indication for the management of heart failure. This is similar to the Canadian Cardiovascular Society recommendations, the same group of medications, ANI, beta blocker, mineralocorticoid receptor antagonists, and SGLT2 inhibitors are all the same medications. And if you take a look at the American guidelines, it is also the same medications that have been approved Nani, beta blockers, mineralocortical receptor antagonists, SGLT2 inhibitors, and then of course all of them diuretics are important if the patient is congested. So once your patient is congested, then think about diuretics. And in addition to the foundational therapy, depending on the patient's characteristics, other medications may be necessary. So if the patient, for instance, has a heart rate that is more than 70 beats per minute, despite optimal medical therapy, then ivabradine may be considered. If the patient has had recent hospital admission, then Beretiquat has also been shown to be important. For patients who are Black origin, then we are looking at the combination of azosulfide, dinitrate, and hydralazine in addition to your optimal medical therapy. And then for patients with atrial fibrillation and things like that, you may wish to anticoagulate them. So the other medications are needed as the patient characteristics will determine, but the 4 foundational medications are applicable to all heart failure patients with reduced ejection fraction. The same message here, just for emphasis, the Canadian Cardiovascular Society, they give stepwise approach, and it is the same message. Foundational therapy, if patient is still symptomatic, then, or depending on the patient characteristics, you determine which other medications are available and can be used. And then step 3 is when the patient has advanced heart failure, then you are looking at other device therapy, support therapy, and other things for them. So don't just go jump ahead and start prescribing ICD for your patients when you have not put them even on foundational therapy. These are important concepts that we all need to achieve. And this is the same thing that the European Society is saying. So if you see this busy table, it is talking about the same thing. The top is your initial action, the 4 foundational therapy. And then depending if the patient is fluid overloaded, diuretics. If the patient is this, that, if the patient is this, that. So the rest is about the characteristics of the patient to then determine what other important medications are there to be used. And then the other important aspect is about exercise rehabilitation. Don't just focus on the medication, but the quality of life of the patient. So exercise rehabilitation is important. And the multi-professional disease management strategy. Heart failure is not a single disease. There are several disciplines that are involved. So you need them to be involved in managing the patient. So the nurses, like heart failure nurses, are important. The physiotherapists are important. There are so many other healthcare practitioners who have a role to play in heart failure. So let's try and get all of them involved.
Hi, Dr.
The last
Agyekum. We have
medication
2 minutes.
2 minutes. Okay, I'm almost done. Thank you. I know you've been generous. So the SGLT2 inhibitors, if you look at the studies that have been done, they have shown significant benefit in terms of heart failure with preserved ejection fraction and heart failure with mildly reduced ejection fraction. So the new American guidelines are recommending them as class 2A indication. And then, of course, diuretics are needed. So if you have patients with heart failure with mildly reduced ejection fraction, that is, they have heart failure symptoms, ejection fraction between 41 to 49%, then you go to drugs, diuretics, SGLT2 inhibitors, and then the other medications, as I've mentioned already, may be used, but the evidence is not as strong as when you have heart failure of reduced ejection fraction. And that is the same thing with patients who have heart failure of preserved ejection fraction, the same recommendation. Ejection fraction is more than 50%, diuretics, SGLT2 inhibitors, and then the others. So this study was done to compare usual care with following guideline-directed medical therapy. And the simple answer is that patients who are put on guideline-directed medical therapy, that is, if you give them the foundational therapy, ARNI, beta blocker, mineralocortical receptor antagonists, SGLT2 inhibitors, compared to the conventional therapy of ACE inhibitors, beta blockers in cross-trial analysis, they do better. So guideline-directed medical therapy improves outcome for patients with heart failure. Remember, heart failure is a deadly condition, and we need to be aggressive in managing it. Thank you.
Thank you so much. Thank you so much, Dr. Agyekum. So we'll go very quickly to Dr. Nani. Hi, Dr. Nani, can you hear us? Hi, Dr. Nani, can you hear us?
So I will stop sharing so that Dr. Nani can share.
Yes, please.
Yes,
Hi,
I'm
Dr.
not
Nani,
I'm not
can you
being
hear us?
allowed to unmute.
So you can unmute yourself now.
Now it's been done.
Yes, so you can go ahead and share your screen now.
Hello. Can you hear me?
Yes, yes, we can. Can you hear me? Hi, Dr. Nani, can you hear me?
Yes, I can hear you. Can you hear me?
Okay. Yes, we can. Please go ahead and share your screen.
All right. Sure.
DJ, can you share just in case Dr. Nani is having challenges sharing from his end?
Yeah, seems so.
Not a problem. Okay, can you share from our end, please?
Can you see it?
No, it's not coming up.
Okay, so he can share from your.
Okay.
Where am I? Wow. Hello.
Yes, we can hear you. We're sharing now.
Okay.
Dr. Nani, I can share from mine so that you continue from here.
Oh, okay. I think I can see it now.
Sure, right. Please go ahead. That's okay.
Yeah, thank you. Thank you so much. Thank you, Dr. Agyekum, for that excellent presentation. So I'll just continue basically from where Dr. Agyekum left off. So I will actually be talking about heart failure management in some special population. I mean, we have quite a number, but because of time, we actually will be speaking about on the important ones that we'll be meeting in our clinical practice offering. DJ, okay, thank you. Is it DJ?
Yes, thank you. Yeah, yes, Dr.
Right.
Nani, go on.
So actually for the special population, we'll start with pregnancy. And the pregnant women are very special to us. So basically, for heart failure in pregnancy, there could be patients who present with pre-existing heart failure. And we'll also talk about those who come in with new heart failure diagnosis during pregnancy. But they are all important for us to know about. For those who have pre-existing heart failure, Dr. Agyekum told us about the stages of heart failure. So there could be some pregnant women who have underlying heart diseases, and basically they may need to be reviewed very well before either they get pregnant or during the pregnancy. And after the pregnancy, they have to be specially taken care of. So for our nurses in the family planning unit, you may have women who will come to you, and I know basically we try as much as possible to take the history, especially hypertension, knowing that some of the drugs we use can predispose these patients to hypertension. But going further, we can also ask about certain cardiac conditions so that we can pick these patients up before they even get pregnant. And so if you look at the slide on the screen, there is actually a way to risk assess these patients who come in before they get pregnant. So we use the modified World Health Organization classification. So we have about 4 classes, and so the classification helps you to risk assess the patient. So for those in the WHO class 1, the diagnosis is there, as we can see. Those with repaired hole in heart, as we call it, ASD and BSD. And then those who are in class 2 are those who have the hole in heart, but yet they have not been operated upon. And then there are also others who have conditions like hypertrophic cardiomyopathy, that's the HCM. And then bicuspid aortic valve, that's the BAV. And these people actually are in class 2 and 3. And then the class 3 will be those with severe asymptomatic aortic stenosis. What it means is that the aortic valve is tight, it cannot open well, as well as those with mechanical valves, those who have artificial valves put in place for them. Those will be in class 3. And for class 4 are those with severe pulmonary hypertension, meaning that the pressure in the lungs, basically the vessels in the lungs is so high, and that pregnancy can actually be detrimental in such patients, as well as those with severe mitral stenosis, those with the mitral valve being so closed tightly that it cannot open well, and those with peripartum cardiomyopathy, whose left ventricular or heart, the contractile ability of the heart has not been regained to its full function. So if you're able to classify these patients right from the pre-pregnancy period, let's say in the family planning unit, then you'll be able to decide where these patients will have their care. Looking at class 4, class 3 patients or individuals, you need to send them to centers where you have experts, the cardiologists, the obstetrician, anesthetists. These people have to be around in order to help actually manage this patient and to determine what mode of delivery going to be used for these patients. So when you look at the other side, it's just the algorithm. For those who are yet to be pregnant and they have this underlying condition, it's important that we counsel them. We tell them they are risk, and we tell them that depending on their risks, the outcome, the likely outcome of their pregnancy. And also we need to tell them if some of them are taking any medication that will have a detrimental or bad effect on the fetus, we have to also speak to them and change those medication. What about if they are pregnant? When they are pregnant, I mean, you just have to assess them using the echocardiogram. You do a clinical assessment to see whether they are actually in failure or not, acute or chronic. You do an ECG, an echocardiogram, as Dr. Agyekum has told us. And then we review the medication that they might be taking. And so in that regard, we have drugs that patients who are pregnant cannot continue with. Even those who are even with hypertension before coming or becoming pregnant. So the ACE inhibitors like lisinopril should be stopped. ARBs like losartan should be stopped. We heard about the ANIs, the sacubitril valsartan, that is Uperi on our market. If they are on it, they must stop it. The MRAs like spironolactone must be stopped. And then SGLT2 inhibitors, which are the new drugs we are using for heart failure, must also be stopped. And on the other side of it, accepted drugs that these patients can be on during pregnancy include the beta-1 blockers, the selective ones like metoprolol and bisoprolol. Hydrazine can be used, nitrates can be used as well. And during pregnancy, as we've spoken about, with regards to the cardiovascular risks of this patient, If this patient is actually in class 2 to class 4, you may have to reassess this patient. Reassessment is needed at the beginning when they conceive and also at 20 weeks. The second trimester is important. Why? Because that is the time the symptoms actually show up, and it's a time where the metabolic demand is high of the baby as well as the mother. And so for those in class 2, you can do once in 2 months review. But for those who are in class 3, especially with a mechanical valve, severe asymptomatic aortic stenosis, you need to see them on monthly basis. But if you assess a patient and that patient is in WHO class 4 risk, there is a need to actually speak to the patient to consider the termination of pregnancy, because the outcome of those pregnancies in terms of the baby and the mother may be dire and it will not be the best for the family. But for those who are low risk, WHO, they have hole in heart that has been repaired, they are doing fine. You need to discuss with the patient, basically, how their treatment is going to, the pattern of treatment, and also possibly you may want to speak to them and refer them to centers if you think you cannot handle. But it's always teamwork. The nurses may pick these patients up early, right from the family planning clinics. They must then tell the doctors about it. And if you're a doctor and your capabilities are such that you may have to refer this patient to a center where you have a specialist, both the cardiologist and obstetricians being around, you do so, and they will plan the care and then as well as the delivery of this patient. DJ. The next slide, please. So there is another category of patients, and these patients may not actually have any heart failure diagnosed before they get pregnant. But however, the pregnancy may actually reveal or unmask a pre-existing condition which had never been diagnosed before. And such patients or women may have valvular diseases or cardiomyopathies. And as I said earlier on, it's important that we review these patients. First trimester, they may be fine. A second trimester, as I said, that is when the demand is high on the body, and so they might come with the symptoms. And one of the conditions we are all aware of, basically, which occurs in pregnancy as a new diagnosis, is the peripartum cardiomyopathy. What it means is that during pregnancy, this individual may not have any underlying condition, but during pregnancy, the contractile ability of left ventricular function of the heart goes down. And when the ejection fraction, the ability of the left ventricle to push out blood, is less than 45%, then you can diagnose this patient as having peripartum cardiomyopathy. And commonly, it's seen in the latter part of the pregnancy and also the first month of postpartum, up to about 5 months. There are risk factors to this. So when we see the patients, our antennas should be high if they have the risk factors and when they are presenting with the symptoms. So African-American race, patients who come in with preeclampsia, it's not just bringing down the blood pressure. We should also make sure that we ask questions that will unearth the presence of any symptoms suggestive of heart failure. Patients or pregnant women with multi-gestation and older women who are pregnant are also predisposed. And the heart failure symptoms in pregnancy can be confused with the normal symptoms of pregnancy. And this is why we need a teamwork. We must work together. If you are seeing the patient for the first time as a nurse and you are not sure, you speak to your colleagues and then you speak to the entire team so that we don't really confuse pregnancy symptoms with the heart failure symptoms. And we also don't miss the heart failure symptoms as normal pregnancy symptoms. Again, during pregnancy, there are drugs that can be used in these patients. And as I said earlier on, beta blockers like metoprolol, loop diuretics like furosemide can be used, but we need to be cautious. The nitrates and hydralazine can be used as well. And then we need to consider the patient throughout the period. If the patient is not doing well, going into cardiogenic shock, there are devices things that can be used to sustain the woman till delivery. And this will be done by the pregnancy heart team, where we have the cardiologist, the obstetrician, the nurses, and everybody on board. I mean, for the outcomes, after delivery, it's known that about 30 to 50% will recover. But yet there are some women who may not recover. They may be at the same level of symptoms, or some may actually have a worsening outcome. So you can actually tell or predict the outcome by looking at the left ventricular ejection fraction, or whether the ventricle is dilated. I mean, African American race have worse outcomes. And if there is delayed diagnosis, the outcome is poor. This is important because we need to pick the patients up early so that we can institute the management so patients can come out clean and well. And for long term, we need to continue. It's not just about giving drugs during the pregnancy period. After pregnancy, we need to monitor and continue managing these patients. And the surveillance is very important, because for the subsequent pregnancy, we need to know the left ventricular ejection fraction, and also to help educate the woman as to how this pregnancy will fare. EJ. So the next special population will be those with iron deficiency anemia. And it's been found now that there's a prevalence of about 50% of iron deficiency anemia in people with heart failure. We don't really check for it, but it's something which we should always think about. The World Health Organization defines anemia as concentration less than 12 for women, 13 for men. And the iron deficiency definition in heart failure is defined as the stores of iron as ferritin less than 100 micrograms or nanograms per mil, or between 100 to 299, with a transference saturation of about less than 20%. And we also need to be aware of the fact that iron deficiency can be present independently of the presence of anemia. So the fact that you do your full blood count and there is no anemia there, per the values we have given up here, it doesn't mean the patient might not have iron deficiency anemia. And up to 55% of chronic heart failure patients and up to 80% of those with acute heart failure may have iron deficiency anemia, independent of the presence of the WHO criteria for heart failure. Is it important? Yes, it's very important to know. Basically, because when the patient is in heart failure and has iron deficiency anemia, there are so many processes that are impaired. And so the recovery of the patient is also impaired and the outcome is worsened. So these patients may have reduced endurance capacity. Their ability to exercise is reduced. They easily get fatigued. The iron deficiency anemia actually impairs the quality of life of the patient, and it worsens the prognosis as well of these patients. EJ. So it's important that we replace the iron. There are benefits of replacing it, because when you replace it, you reverse all the factors we spoke about earlier on. It improves the exercise capacity of the patient, improves the quality of life of these patients. It also reduces the all-cause death and cardiovascular hospitalization as well. And whether you have, or whether there is anemia, per the definition we gave, there's always a favorable effect of iron supplementation if there is iron deficiency anemia. How do we replace it? Should we give oral? Should we give IV replacement? Studies have been done, basically. And so we look at the CONFIRM, we look at the FAIR-HF, putting all these data together. It's been documented and accepted that IV replacement is best. I mean, if you look at the orals, studies have been done using high-dose oral iron polysaccharide, and really, it did not improve the exercise capacity nor the quality of life. So the oral replacement is not the best to give in patients who have iron deficiency anemia. And so let's have this in mind. If you have a patient who has anemia, iron deficiency, don't keep the patient and just give oral Totima, which we know, or the iron tablets that we have in our facility. We may have to refer them to a center where they can have their iron replacement being done, and how to do it where the person seeing the patient knows how to give their IV replacement. DJ.
Dr. Nani, you have 5 minutes.
Okay,
left.
so the next.
Yeah, Dr. Agyekum, you can also respond to some of the questions in the chat as well. We have people sending in their questions. Okay, please go on, Seth.
So the next group of people, special group of people, are those with kidney dysfunction. More so because they share a common risk factor with heart failure, hypertension, diabetes. So if one is present, there is a need to look for the other. And those with chronic kidney disease, there's a major impact on mortality, death. It increases the mortality of patients in heart failure. And there is this relationship between the heart and then the kidney. So CKD can worsen the outcome of heart failure, and heart failure can worsen the outcome of CKD. They are also related signs and can be confusing. A patient with CKD with pulmonary edema can present, and we can think is actually heart failure. So there is a need to understand how kidney dysfunction affects heart failure, and to manage accordingly. In terms of the drug management, in those with kidney dysfunction, if you start management, you will see some changes in the creatinine and then the eGFR as well. And if you are not abreast with it, you might think that the kidney is actually going down. But if you look at drugs like the RAS inhibitors like Sinoprol, Losartan, you're looking at ANIs like the sacubitril valsartan, SGLT2 inhibitors like dapagliflozin. When you start them, there will be an initial decrease in the eGFR and an increase in the serum creatinine. But if you are not sure, kindly refer so that this patient can have a second review. And there are some medication that also improve CKD in heart failure. SGLT2 inhibitors, ARNI use, have been shown to improve kidney outcome. We also have to be aware of the fact that in patients with CKD, the medications we give in heart failure, which are mainly part of the foundational drugs, may also lead to hyperkalemia. And so we should be aware of that. DJ. Diabetes. We encounter patients with diabetes on daily basis in the clinic. And I have listed all the medications available so that we can actually know how to deal and which ones to use and which ones are preferred. And so in your choice of patients with heart failure with diabetes mellitus, in terms of the drugs to use, you have to choose drugs that are both safe and reduce heart failure related events, those that decrease mortality and morbidity. So let's talk about the SGLT2 inhibitors. We have had examples like dapagliflozin and empagliflozin. And so if you are not aware of them on the market, we have and for Zega, we have Jardians as well. And these are the drugs that are the SGLT2 inhibitors. It's recommended in patients with type 2 diabetes with heart failure with reduced ejection fraction. Why? Because it reduces hospitalization for heart failure and cardiovascular death. And this actually is documented. If you are in a setting and you have means and you have all the drugs available, in a patient with heart failure and with diabetes, I think the best drug to go for, it will be the SGLT2 inhibitors. If there's one drug to start with, it should also be considered in patients with heart failure with preserved ejection fraction. Next slide. So for metformin, which is so common in our facilities, I mean, all of us have access to it. And the good thing is that metformin is thought to be safe in patients with heart failure compared with drugs like insulin, sulfonylureas, and these are based on observational studies. However, it's not recommended in patients with eGFR of less than 30 and hepatic impairment. So it's important that as part of our evaluation of this patient, we look at the kidney function and the liver function as well, because it can lead to lactic acidosis and worsen the outcome of this patient. If patient comes in acutely, it may not be good for you to give the metformin at that point. It's good to start when the patient is stable. For dipeptidyl peptidase 4 inhibitors, and we know them, vildagliptin, saxagliptin, brands like Galvus and Onglyza on the market. The truth is that they are not recommended to reduce cardiovascular events in diabetic patients in heart failure. I'm not saying they are not recommended in diabetics. Diabetics with heart failure, it's a good drug for patients with diabetes without heart failure. But when it comes to choosing drugs for heart failure with diabetes, studies have shown that they are not the best. They are not recommended, basically, so we should be aware of that. The next slide talks about the use of insulin in heart failure. Next slide, please. Insulin in heart failure, if it is needed, we have to give it to these patients. But however, we need to monitor for evidence of worsening of heart failure, because insulin actually retains sodium. And so if you are going to give it, you should monitor this patient for worsening heart failure if you initiate treatment. And for the sulfonylureas, the glibenclamide, we know of Daonil, glimepiride, they are associated with sometimes increased rates of heart failure events, and they are not preferred. And so even if we are going to give it to our patients, especially when we don't have the luxury of the other medications around, anytime we start it, we should monitor for evidence of worsening of heart failure after treatment initiation. The last one we know about, and it's also available in the district and in secondary the regional hospitals, is the glyzones. An example is pioglitazone, which is very popular. The truth is that it increases the risks of worsening heart failure and hospitalization. So it's contraindicated. You have a patient who has heart failure, is diabetic, he's on pioglitazone, it's best to change it to another molecule because they are contraindicated. Unlike the sulfonylureas and insulin, where you can give them and monitor for evidence of worsening of heart failure. The last group of people I'll speak about is will be the elderly patients. Next slide, please. These patients are very, we see them on frequent basis. The elderly, please, the next slide. The elderly patients are seen on daily basis, and the prevalence of heart failure is also high in them. The other issue is that they have worse prognosis and they have a high residual disability. And the cause of heart failure in these patients are complicated by the complex presence of the other morbidities. And it's because of the fact that whilst we are growing, there are physiological changes in us, and that negatively impacts on the disease process and also the drugs that we give to them. And so if you look at changes like, if you look at the physiological changes, there's decreased cardiac reserve. So patients, there's a potential of heart failure with some calcium channel blockers. They have decreased LV compliance. So, I mean, the decreased output when we give them beta blockers. They have a decreased baroreceptor sensitivity. So they have orthostatic hypotension. When they stand, BP drops. So when you give drugs like the nitrates and beta blockers in heart failure, it causes problems. They don't respond well to drugs. So if you give beta blockers again, they are not able to respond very well. And they have an increase in prevalence of sinus node diseases and then AV node diseases. So if we are giving some of the drugs that are foundational, especially the beta blockers, we have to be careful because we may actually cause higher degrees of blocks. The next slide, please. For the management of this patient, what I would like to say is that we have to carefully consider the comorbidities, the polypharmacy in elderly patients, Polypharmacy means that they are taking quite a number of medication for so many ailments. We need to look at the side effects of these drugs, and also we should be able to manage the aspiration of these patients. The concept of starting low in elderly patients and going slow, what it means is that if you are initiating any drugs in the elderly, please start from low doses and graduate upwards. And you titrate that against the side effects that they might present with. And that will help mitigate against some of the effects that we can have in the elderly patients. Please, the next slide. I'm about finishing. So looking at the drugs that we use in treating the elderly patient, the next slide, please. We give the foundational drugs as we have been taught. Next slide, please. Hello. For the foundational drugs that we have spoken about, as Dr. Agyekum mentioned earlier on, if you look at the ANIs, the sacubitril valsartan, it's effective across the ages. But remember that in elderly patients, there's an increase in the side effects of hypotension and hyperkalemia. For beta blockers, they have increased presence of fatigue and bradycardia. And so we need to start slow and then titrate. And for beta blockers as well, studies have been done, especially with a drug like nebivolol, which shows that nebivolol is actually good in patients over 70 years. It decreases both the mortality and hospitalization. Remember that in as much as they have the side effects from these drugs because of their age is not a contraindication to the use of beta blockers. And so if you have to use it, you just have to use it, but make sure that you are monitoring the patient very well. The next slide, please. So how about drugs like spironolactone, which is common and available at our facilities? If you have to use them, you can use them. It's equally beneficial in older patients. Again, the side effects are what is heightened in these patients. Digoxin is also beneficial. So I'd like to conclude and say that the evidence-based therapies have been found to be efficacious in the elderly population. All that we need to do is that we need to individualize the approach to therapy whilst we weigh the benefit versus the adverse effects and the goals of care. And what are these goals of care? Next slide. The goals of care for every patient as an elderly patient is that we are looking at the problem of polypharmacy, so we try to minimize polypharmacy and the potential of drug-drug interaction and disease-drug interactions. We also need to look at the comorbidities and manage them well accordingly. Cognition is very important. The elderly may not, if you have a patient who is elderly and has a decline in their cognitive abilities, you should know that there will be a problem with the intake of the medication. And here, you need to speak to them all right, but you also need to involve a caregiver. And frailty is very important. Some are very frail. And so whilst you want to tighten the care, you must also be aware that the side effects of the drugs may be dire in this patient. And most importantly, because of their age and physiological changes, there are heightened adverse effects in them. But we should put all these things into perspective. Thank you very much for your attention.
Thank you so much, Dr. Nani. Thank you, Dr. Agyekum, for also sharing the screen. I just realized you were the one that was sharing for him like you promised. So thank you for looking out. Well done, everyone. We have a number of questions in the chat. Dr. Agyekum is also responding to some of them. So we would have Dr. Nani, please also, there were questions whilst you were speaking as well, if you could respond in the chat. We will go very quickly into the case presentation so that we can also discuss. I think we have Dr. Mavis here on the call. So very quickly, let me see, is Dr. Mavis here? I know I saw Dr. Mavis. We have a presentation from Achimota Hospital. So we'll quickly take that. Yes. Okay, please, can you go on, Dr. Mavis, please go on. You have 5 minutes to present. You're
Yes,
unable,
hi. Thank
okay,
you.
yes, please go ahead.
Yes, I'm back in now. Thank you, Dr. Agyekum, Dr. Nani, for that comprehensive presentation. So I'll quickly go through the case presentation. Next slide. So I'm Dr. MBChB from Achimota Hospital. We had a case of a 57-year-old male, Mr. M.A., who reported he was married, he was a trotro driver, and was NHIS insured. Next slide, please. Next slide, please. Please, can you hear me?
Yes, we can hear you.
Can you please help change the slide? So the patient presented with difficulty in breathing and bipedal swelling of a 2-week history. Please, the slides are not changing.
I think it's frozen. Just give me a second.
Okay.
Okay. Can you see the screen now?
No, it's not up yet.
Is it up now?
Yes, I think it's, yes. So the patient presented with a 3-day history of difficulty in breathing and a 2-week history of bipedal swelling. Please, next slide. So the patient was a known hypertensive and a diabetic who was not compliant on medications for more than 2 years. He noted he started having progressive bipedal swelling with breathlessness on exertion over the past 2 weeks that had progressively become difficulty breathing at rest over the past 3 days. The patient also noted he had cough that was productive of whitish sputum with associated orthopnea and then easy fatigability. He initially had managed the symptoms with over-the-counter medications, but later reported to a peripheral facility when the symptoms got worse, and he was subsequently referred to us. On presentation, he had paroxysmal nocturnal dyspnea, he had palpitations, he had polyuria, but there was no other symptom of chest pain, early morning facial puffiness, abdominal swelling, or frothy urine. Please, next slide. His past medical history was, this was the first of such an episode of difficulty in breathing with bipedal swelling. He was diagnosed with hypertension about 10 years ago during a routine screening. He was started on medication, but patient was not compliant. 2 years ago, he had very high BPs for which he was admitted. He was also diagnosed with diabetes mellitus during that same admission 2 years ago. Patient was started on both antihypertensive and oral hypoglycemics, but defaulted. He has had no other chronic illnesses and has had 2 admissions on account of high blood pressure. Please, next slide. So he was initially started on nifedipine 20 milligram BD and twice daily. He was also started on tab metformin 1 gram twice daily. He uses over-the-counter medication, that is tab diclofenac 100 milligram BD for occasional waist pain, and has significant use of herbal preparation use. Next slide. Family history is significant of hypertension and diabetes in both